Why does one patient have an adverse reaction while another does not, even on the same dose? To answer that, you need more than a timeline. You need the pharmacology that makes a suspected reaction plausible or leaves it much weaker. A case narrative can record what happened, but it helps little if it cannot explain how it could happen. Causality assessment asks whether a pharmacological mechanism exists. Half-life, interactions, and special population physiology all help you judge whether a reaction pattern is meaningful. Pharmacokinetics is what the body does to the drug. Pharmacodynamics is what the drug does to the body. Drug exposure is shaped by absorption, distribution, metabolism, and excretion, the four parts of the ADME cycle. Absorption is movement from the site of administration into the systemic circulation. Intravenous dosing bypasses absorption. Bioavailability is the fraction of a dose that reaches the systemic circulation unchanged. And for intravenous dosing, it is 100%. An oral dose enters the portal vein and passes through the liver before reaching the rest of the body. First-pass metabolism removes drug during that first journey through the gut wall and liver. High first-pass drugs can show low and variable oral bioavailability. Distribution is movement from blood into tissues, shaped by lipid solubility, protein binding, and tissue perfusion. Volume of distribution is an apparent volume, not an anatomical one. Clearance is the volume of plasma cleared of drug per unit time across renal, hepatic, and other routes. Clearance and volume of distribution together determine half-life. Half-life is a derived value, not an independent property. When the clearing organ fails, clearance falls. So renal or hepatic impairment can raise exposure even if the dose is unchanged. After n half-lives, the fraction remaining is 1/2 to the power n, so 5 half-lives leaves under 4%. On repeat dosing, accumulation reaches about 96.875% of steady state after 5 half-lives. The same working figure helps estimate washout. A drug with a 12-hour half-life reaches steady state and washes out in about 60 hours or 2.5 days. Amiodarone has a labeled plasma half-life of the order of 50 days. 5 half-lives is 250 days, or roughly 8 months. A dose-related reaction driven by accumulation cannot appear until concentrations move toward steady state. That means long half-life drugs can produce genuinely late-onset events. D-challenge is informative only if several half-lives pass. So a negative result too early may tell you nothing. Phase 1 metabolism includes oxidation, reduction, and hydrolysis that add or expose a reactive chemical group. Phase 2 metabolism attaches groups such as glucuronide, sulfate, acetyl, methyl, or glutathione to increase water solubility for excretion. Metabolism usually inactivates a drug, but prodrugs are activated by it. Cytochrome P450 enzymes drive most clinically important phase 1 oxidation, mainly in the liver and small intestine. The 5 highlighted here are CYP3A4, CYP2D6, CYP2C9, CYP2C19, and CYP1A2. Each matters in interaction and phenotype assessment. CYP3A4 handles the largest share of clinically used drugs, and midazolam and triazolam are listed as clinical index substrates of CYP3A. CYP2D6 metabolizes many antidepressants, antipsychotics, and opioids, including codeine. CYP1 A2 metabolizes caffeine and tizanidine, and tobacco smoke induces its activity. A strong inhibitor increases the area under the curve of a sensitive index substrate at least 5-fold, while a moderate inhibitor raises it at least 2-fold but less than 5-fold. Enzyme inhibition is usually rapid because it begins when the inhibitor reaches the enzyme. Clarithromycin and itraconazole are listed strong CYP3A inhibitors. Ketoconazole altered terfenadine pharmacokinetics with measurable electrocardiographic consequences in a reported study, and terfenadine was later withdrawn over QT prolongation and interactions. Grapefruit juice furanocoumarins irreversibly inactivate intestinal CYP3A4. Reported simvastatin exposure rose by 330 to 700%, risking rhabdomyolysis. Induction increases enzyme production, so onset and offset are slow and usually take days to weeks. A strong inducer decreases the area under the curve of a sensitive substrate by at least 80%. Rifampicin, carbamazepine, and phenytoin are listed strong CYP3A inducers, and rifampicin also induces CYP2C19. Induction often causes loss of efficacy rather than toxicity, though toxicity can appear when the inducer is stopped and clearance falls back. A reported case linked St. John's wort with acute heart transplant rejection through interaction with cyclosporin. The MHRA also reported yellow card cases with hormonal contraceptives, including unplanned pregnancies. Genetic variation in metabolizing enzymes creates poor, intermediate, normal, rapid, and ultra-rapid metabolizer phenotypes. For an active drug, poor metabolizers can accumulate parent drug and face more dose-related toxicity. For a prodrug, the logic reverses because metabolism is needed to create the active form. Codeine is converted to morphine by CYP2D6. The MHRA restricted pediatric use after life-threatening events, including death, in ultra-rapid metabolizers, and codeine is contraindicated in identified CYP2D6 ultra-rapid metabolizers. Clopidogrel is activated principally by CYP2C19, and its United States label warns of reduced effect in poor metabolizers. Most drugs act on receptors, enzymes, ion channels, or transporters, and selectivity is rarely absolute. An agonist produces a response. A partial agonist gives a submaximal response, even at full occupancy. And an antagonist blocks the agonist without producing a response. Potency and efficacy are different properties. The therapeutic index compares the exposure causing toxicity with the exposure producing the desired effect. A narrow therapeutic index means small changes in clearance can matter greatly. On-target toxicity is usually predictable and dose-related, while off-target toxicity arises from a different molecular target and may be unexpected. Neonates and infants have immature phase 1 and phase 2 enzymes and immature renal function, so clearance is reduced and variable. Older people often have reduced renal clearance, altered body composition, and polypharmacy. In pregnancy, physiology changes, and valproate is reported to cause physical birth defects and neurodevelopmental disorders after in utero exposure. Renal impairment reduces clearance of renally excreted drugs, while hepatic impairment reduces metabolic clearance and can also raise oral bioavailability. Metformin is cleared unchanged by the kidney, and the EMA concluded it remains contraindicated below a glomerular filtration rate of 30 milliliters per minute. In causality work, Rawlins-Thompson types A to F and pharmacological plausibility help turn observations into testable explanations. You have seen how exposure, mechanism, interactions, genetics, and patient factors shape adverse reaction risk. You have also seen why half-life, de-challenge timing, and on-target or off-target reasoning matter in causality and signal evaluation. When the mechanism fits, the case becomes much stronger to assess.